So back to it, welcome to part 2, and this time we're having a look specifically at the foreign bodies and some lesions. So straight into it. Now we are finding any foreign bodies, generally they're going to be in that subcutaneous layer, in the very superficial tissue of that subcutaneous fatty layer that you're going to see. It can be found because of trauma, so obviously a lot of us would have had an experience where we've had a foreign body, actually usually around the hands and the fingers, those sorts of places. You might have been gardening and got something that grazed along your leg and ended up with some splinters in there, all those sorts of things. You can also have some foreign bodies from your therapeutic procedures as well, and some are intentionally meant to be put in there. Often you will be asked to find an implanon in one of your patient's arms. Sometimes they migrate a little bit, they can't be found or palpated, and you'll be expected to try and find that little rod that gets inserted into the arm in female patients as a pregnancy deterrent or as a contraceptive device. So there can be a few different reasons why you're going to be looking for foreign bodies in those subcutaneous tissues. What sorts of foreign bodies do we have? As I've mentioned, any of you who are the keen gardeners will have the splinters and the thorns in the organic material. Now, obviously, with organic material, there is going to be a high risk of infection. Often there is potting mix involved, which is highly infectious. Dirt surrounds, rusty things like rusty nails and those types of things are going to cause that infection, and we'll talk a bit about that later on. Now, the inorganic foreign materials or foreign bodies, glass, that's a tricky one. Gravel from people having busters on their bikes or something like that. They'll often have all of that gravel rash that you'll see first. The doctor or the GP or whomever, nurses, emergency department may have already tried to pick some of those foreign bodies out, and something may still be left, or the patient may be able to palpate some lumps a little bit later on after the initial healing. So we'll talk a bit about that later as well. Plastics, pencils, leads, often very, very common for people to have poked themselves with a pencil, the lead's broken off and is left in the skin itself. Metallic, you'll get some different bits of wire, barbed wire, for instance, for the farmers who are doing fencing, needles, and those all popular fish hooks from that weekend fishing trip. Now, a little bit about sensitivity and specificity. Now, sometimes it's a little bit hard to get your head around if you just think about them as one being true positive and one being true negative. So for sensitivity, if something is sensitive, it means that that particular instrument is able to detect a patient or someone having the disease or having what it is that you're looking for. So in the case of a foreign body, the sensitivity of detecting foreign bodies would be those patients that do have a foreign body and that ultrasound is able to find that they do have a foreign body embedded in their finger, for instance. The specificity, the true negative, is actually if someone might have a sore finger or something, they think maybe there was a bit of glass in there, they pull most of it out, and they think there may still be something left in there. The true negative is actually for ultrasound to scan a hand or a finger or whatever it is to see that they don't see anything, there's nothing there, and that in actual fact there has been nothing there. So the true negative, that the healthy people identified as being healthy is not having what it is that you're looking for. So sensitivity, yes, we're great, we've found it, we're awesome sonographers, and we've found that foreign body. Specificity is they've had something but we can't find it, and then later on down the track it's been shown that there wasn't anything there, so that we were accurate and correct in saying that there was no foreign body in that particular patient. So I did want to bring this back to these gorgeous images that are from the photoelectron microscope, and this is actually a skin cell, so you can see how it does start to peel off from those deeper layers, and then it sloths, so it comes off in sheets. You might have heard people describing things. Well, that's what it is like under the electron microscope. And this here as well is a keratinocyte, so it's one of the skin cells itself, so they look very, very cool. In terms of sensitivity versus specificity, Sensitivity, so how often can we detect something that is there in the skin? 95%. So that's really great, isn't it? Really high levels of sensitivity. Specificity, not so much, and you can understand that. That means that 89% of the time we say that there isn't anything there and that there isn't anything there. So we can have some false positives going on in there, and that's why that is a little bit less than the sensitivity. So sometimes detecting that there might be something there when actually there isn't anything there. And when we look at artifact a bit later on, you can understand that we may overcall some things and think something is a foreign body when actually it's an air bubble or something like that, which is causing some sort of an artifact. Better rates of detection with any foreign bodies that are over 2.5 millimeters. Now, that is still small, very, very small, and that's going to be felt by your patient. If something becomes smaller than to a 1 millimeter, it still can be detected, but is becoming more difficult. Obviously, anything less than a millimeter is really, really hard to try and identify, because the frequency of the very, very highest frequency probe still is not able to have quite enough beams so that they can see anything less than 1 millimeter there. With the scan, now hopefully you might have seen some of these around, there is something called sterile gel. So we don't just wash the canisters out, put more gel in them and use the gel that's been warmed. These come sealed, they are sterile, and they are to be used in certain situations. One of them is any time that there is an open wound. Now that also might just be a puncture wound or little tracks of blood or dried blood or scab or something like that, where you can see an opening of the skin. You must use sterile gel, particularly when you're thinking about foreign bodies, because of the risk of infection due to the nature of the foreign body that may be in the person. Another area that you would use sterile gel is when you're doing a pelvic exam, which you'll be doing next term. However, with the transvaginal transducer, which you will do in year 3 on the phantoms. So if you are out on clinical at the end of this year and you are preparing the transducer for your sonographer for the intracavity examination, you must use sterile gel after you've put on the probe cover. So that's just something to bear in mind. Now, when you are looking for a foreign body, as I've said to you in previous weeks, as a sonographer, you need to have your detective's hat on, and you need to be trying to use all of your clues to find where that foreign body is. They can migrate, so they're not always going to stay exactly where you think that the entry mark is. They will go into the skin and they can start migrating and moving. So you always need to try and see where that entry mark is, where that track is going to be, and see if you can try and follow it. The track is going to be usually a fluid-filled track, so hopefully you realise anything that's going to be fluid-filled is going to be hypoechoic, and you'll be looking for that as a hypoechoic. Sometimes you'll get a bit of a halo around the foreign body as well, so you're looking for that to aid in the detection of the foreign body. Why do we not have harmonics on? Hopefully you can all remember your physics, that we use harmonics if we're looking at anechoic structures or anything that's fluid-filled particularly. We also use harmonics to get rid of artifact. With foreign bodies, sometimes they're so small that we need to use the artifact to help guide us to where they are. So we do want reverb and shadow artifact so that we can see where the foreign body might be. So certainly never put the harmonics on, no matter what you think. With the foreign body scan, as I have said, particularly with that organic material, if you've got palm fronds, I'm from Mackay, so I've had lots and lots of people coming in who have done their gardening and have got those nasty little palm fronds stuck in their finger and they just cannot get them out. They are organic material, they may have had potting mix all over them, and they will cause that inflammation and infection. With that inflammatory reaction, you're going to have that higher vascularity. You may even be able to feel that there is more heat around there. You're going to have more of that fluid-based reaction coming there, so there's going to be that swelling. You'll see more of a softened lump, which isn't the foreign body, that's just that inflammation response. And as there's more vascularity, you will have more of a reaction when you put the colour Doppler on or the power Doppler. Now remember the difference between colour and power Doppler. If you've got a very, very small area that you're trying to look at with very low flow, you're going to be using more the power angio Doppler than the colour Doppler, because it's going to be more sensitive for you in trying to detect that inflammatory reaction. Use the highest resolution for the depth. Now we really need lots of resolution with foreign bodies. Being superficial in that subcutaneous layer, we should be using our big high frequency probes, like the hockey stick, for instance, if it's in little small areas around the finger, or some might have a nice 17 probe, which is a bit more of a specialist probe, or at a last resort, the 12 probe of the linear. So make sure that you are trying to get the very highest resolution that you can. A lot of the time you might use a 12 or a 17 in the general vicinity once you identify where the foreign body is, and then switch to the hockey stick so that you can get a better appreciation of where it is, and looking for those track marks, etc., to see if there's any other fragments that might be surrounding that area. You do need to mark the skin. Often that patient will be going back to the hospital or the GP for removal of the foreign body, so it's important that you do mark the skin with a marker that I've got there, and that's going to aid in your detection of the foreign body for the person who's going to be removing that at a later date. Now the appearance, a little bit more just on marking the skin to assist removal. Often they may have come to you already with a doctor's visit that they have attended to previously, so there may already be a little cut where someone's tried to dig around and find it. So again, that's something that could be introducing infection, and you need to make sure that you use that sterile gel. With the appearance, they are mostly going to be echogenic, so they're going to be, we often say if it's as bright as bone, so that we don't get any of those false positives that I was talking about earlier. So quite bright, quite echogenic. You'll often get this comet tail artifact, particularly around metal, rounded fragments, glass, those sorts of things, where it's got a bit more of a curved surface. You can get clean or dirty shadowing. It's going to be more of a dirty shadow if you've got sort of a broken linear structure, and the cleaner shadowing is going to be from the smaller, rounded, particular foreign bodies. Now you can get air within that soft tissue, and you know when you've seen air previously that it does mimic this comet tail artifact. So it's very important that you look in those two planes, that you surround the structure, you angle from different areas, you slide into different sections and to different regions to try and get that foreign body perpendicular or 90 degrees to the transducer, and making sure that it's real and it's not artifact. So lots of sliding around, investigating. Usually if it's fingers or something like that, that's easy to do, more so than if it's in a larger area of the body. Now here we have our linear foreign body here, which is echogenic. We can see it, and it's quite new. There hasn't been any sort of response occurring afterwards. So once we get generally after 24 hours, you will start to get that air replaced by fluid, and it's a little bit harder to see. However, once that fluid starts to build and you get the inflammation response, it becomes greater, and then you'll start to see the mound or the soft lump which is caused from the inflammation. It then becomes easier to see. So it has just this small window where it could be quite difficult. That could be the time that they're coming to you to try and find it. So just because you don't see it on the one occasion doesn't mean 24 hours later it might be a little bit easier to see. So I always make sure that I tell my patients to go back to the doctor or your GP or your referrer, and if they still haven't been able to find anything, come back and have another scan in a day or two. Here we can see it's a little bit older and it's starting to be a little bit more echogenic. We can see this anechoic or hypoechoic halo starting to occur as well, so it's aiding in the detection for that structure. So back for wood here, as you can see, most of the time they're those linear structures. They don't tend to be a rounded structure, being wood shavings or splinters, those sorts of things. With glass can be varied types of structures, and it can be rounded, they can be just shards, a little bit harder to see. Glass does make me nervous, it's a bit trickier, and because it's so shatterable, you can have various fragments and you never know if you've got all of the fragments there. So if any of you have ever stood on a piece of glass, you might still feel that there's something there, 2 or 3 months later. It's quite tricky. So you can see they're more rounded. Again, they're echogenic, so bright. Think that saying bright as bone here, as opposed to something else in the surrounding tissue. We're seeing that hypoechoic halo starting to occur, which I'll talk a little bit about later, and you're going to see posterior shadowing. So here we can see that shadowing. That's the artifact that we're looking for. We've got a little bit of reverb coming down here with that ring down as well. So look for that posterior shadowing here. We're looking for a displacement in the structure, so we can see this is all very nice and homogeneous, and then we can see these echogenic structures here, which are little glass shards. The age, I've talked a little bit about that just then with the foreign body. It's important to ask your patient with the patient history, how long ago did this incident happen, so that you've got a bit of an idea. So within 3 days, it's quite acute. You're going to have that white, bright, echogenic posterior acoustic shadowing going on. More than 24 hours, you're going to get that hypoechoic ring that I talked about as that inflammation is starting to occur. It surrounds the foreign body and is going to help you to see. But just before that, just prior to that, it makes it a little bit more difficult. So as I said, give it at least another 24 hours if you're still unsure. 3 to 10 days, that hypoechoic ring becomes a lot more pronounced. You're going to get more vascularity. Make sure you put that power angio Doppler on there, and that can often just target it for you, so you can do a much more specific scan and see exactly where the foreign body is, because the colour has guided you into the right area. Greater than 10 days, you're going to still have that inflammation. Generally, it won't resolve within 10 days, and you'll start to get the granulomas occur as you get fibrosis going throughout that inflammation area. So on top of that, you're going to have granular material, the breakdown, particularly if it's organic material, you're going to have a breakdown and it becomes quite difficult to see. If you've got this nice big fluid area around it, however, that's going to be your guide, and you'll be able to hone in and see if you can actually find the specific foreign body. So here we can see where we've got that anechoic region of fluid surrounding, so we can see it nicely. Here's those superficial layers. We can see this nicely. We could be putting on our power angio just to make sure there wasn't a vessel or something there, if we were thinking maybe that's a vessel. That would also be tubular and anechoic. And here we have the foreign body here. We've got some of the reverb going on down there as well. So just all of these little clues to help you identify these foreign bodies. Here we've got a few more examples of the granuloma. So this was glass, so it's rounded, quite small. Here we've got medial and lateral being identified, and you can see it starts to lose that echogenicity as that granular formation occurs. Here is a bee stinger, ouch, makes your eyes water as you automatically think about it. But again, you've got that shadowing, so there is enough of the original composition of the foreign body still there, hasn't degraded enough, but you're starting to see where the granular formation occurs, and you're getting that echogenicity into the middle part of that foreign body. Removal, that's why they're coming to you. They want that out of there. You need to document a few more things for foreign bodies than what you would when you are measuring an organ, for instance. First and foremost is the depth. That surgeon, doctor, GP wants to know how deep they have to go to be able to remove that. So it's important to, when you're measuring, so you can see here's the calipers 1 and 2, that you would be measuring the depth here. So if this was where your marker end was, whatever, if that was medial or lateral, or if it was in longitudinal, if that was towards the head, you would say how far from the skin surface this section was at its deepest part, and how far this part was from the surface. So you would be saying anteriorly or superiorly, depending on how this image was taken, and you would need to write that down, of course, where the deepest part was, so that the GP or the surgeon knows exactly where they're going. How long it is, obviously, so they know that they've got it all as well. Trying to make sure that you are giving them an idea of the shape. Is it a linear structure? Is it comprising of several shards? Are they rounded? Often you'll get little, often see in textbooks. I've not seen them myself because I haven't seen any shooting victims or anything like that in general practice, but you might see like little shots or something like that have been from little play guns and those sorts of things that can also penetrate the skin. So make sure you let them know whether it's a linear structure, if it's rounded, curved or shards. The orientation and position, so that should already be in marker on the patient themselves, and with diagrams, usually on a generic type of worksheet that you would have for foreign bodies, there is an outline of a person, and I'm a huge fan of diagrams. So if it was in the hand, I would draw the outline of the hand, which is medial, which is lateral, and the direction that it's lying, where the deepest aspect is, if that's going to be medial or lateral, for instance. The more information you give them, the better it is, the less pain it is for the patient, the fewer incisions that need to be made to have that foreign body removed. Obviously, we're taking images in long and trans as well, and trying to identify the tracks. So if you can see that anechoic track mark, and you'll be able to try and measure it, follow where it goes, and then see where that foreign body has migrated to. Identifying the track marks also will help the surgeon or the person removing it, if it has actually, sometimes they will go in at a specific angle. So when the original GP was looking, they will penetrate straight down, and it may have gone at quite an angle, so it has gone a lot more laterally or medially than where they were originally looking for. Limitations of the scan. Now, hopefully you're understanding that there are limitations to what we do, and there are certainly a lot of things with foreign bodies being so superficial that hamper our ability to detect them. So they are obscured by bony structures. Even though we say things bright as bone, well, we also can have bone in the way, and it's very, very difficult to know which is the foreign body and then which is being covered by the bony structures. So make sure though, if you do have a joint or a bony structure that is somewhere in the vicinity of that foreign body, that you also measure from that foreign body to that landmark, and that will also give a bodily landmark for that person removing the foreign body as well. Now, if they have had a visit already to the hospital or doctor, they may have had an anaesthetic, a local anaesthetic, before the medical professional has used the scalpel or made an incision, and unfortunately that hampers our job for us because it introduces air bubbles, and as we've just talked about, air bubbles can mimic glass shards, for instance, so it makes it very, very hard for us to be very definitive about whether or not there is still a foreign body in there or not. Any types of calcifications, as you know, if there are previous granulomas or scar tissue from previous operations or previous injuries, hematomas, they can mimic a foreign body and make it very difficult for you to make a call whether it's a positively identified foreign body or not. And as I've talked about, small glass fragments certainly can mimic air. Now, on to lipomas, our little bumps. Now, these are a common area that we scan, and it's a cause for concern for people because they will feel a palpable lump. They are harmless, they are benign, but very, very common. They can occur anywhere in the body, and much to your patient's dismay, they will find that it is just a lump of fatty tissue. It's quite offensive for people to think that they've just got a bit of abnormal fatty tissue that is just growing and proliferating for no reason whatsoever in a particular area. It can be unsightly. If it really bothers them, then it is surgically removed. But they're very soft and squishy, they're compressible, soft tissue masses. There is a familial predominance, so often ask your patient, has any of your family had lipomas or had these lumps in the skin that have been removed before, more so in males as well. Now the back, the shoulder, the upper arms are most common. A lot of males, however, do get them in the groin area, and they'll just have this lump, which is often confused with an inguinal hernia. So it's important that you get them to strain if it is down around that inguinal region or that groin area, to make sure that it isn't a hernia, that it is just that soft tissue. Around 50 to 60-year-old, although I have found it can be in much younger people, particularly around the arms. I've seen quite a lot around the jaw here as well, where people find just a lump starts occurring. So they can be anywhere, usually solitary, but unfortunately if you do have one, you have more of a tendency to get some more. Now, some are really, really easy to see, and some are very subtle. You can put the probe on and think, now I can feel it. I've actually palpated a patient's lump, absolutely felt it, put the probe on, looks like there's absolutely nothing there at all. So you have to look for these little subtle changes. You can see that sort of like a whirl-like effect here within that subcutaneous tissue and that fatty layer. So here's where the calipers are. We can see that there is a little bit of edge shadowing, so we can see there is a slight distortion in that fatty tissue composition, which is our clue that there is a lipoma there. Here are a few more, and if you can adjust your eyes, you can see sometimes they are difficult to see. They tend to be almost cloud-like, little fluffy areas that you can only just make out. Often you'll see that there will be more of a distortion in the skin layer, particularly if it's very superficial, and that will guide you in order to try and find the margins of the lipoma so that you can see it a little bit better. This one is quite encapsulated, so you can see it a little bit better than some of the others. So they have varied appearances. Some are quite encapsulated, some are just that sort of fluffy area like we've got here. So you need to just listen to your patient, palpate. We are very hands-on as sonographers. Put the probe on it and then see whether you can see some of the clues that I've talked about to identify that lipoma. Always I would put colour Doppler or power angio on as well, just to be sure and make sure that it is not a lymph node or a reactive lymph node as well, because they can appear in similar places. So what do they look like? Usually elliptical, ovoid types of shape. They're compressible, so that's where you would do your dual screen, have the lipoma, and make sure that you also have the compression on the other side, and you just slightly depress the probe and measure the difference so that you're proving that it is able to be depressed or compressed. Short linear striations parallel to the skin, so you're going to see where those fatty layers come through, and they're going to be more of a vertical layer which is parallel to the skin, like a normal fatty arrangement that we've seen before when we did the breast on the breast tissue layers. Varied appearances I've mentioned before, and some are difficult to differentiate the margins or the borders. You'll just see this slightly more echogenic. They'll be hyperechoic compared to the surrounding fatty tissue, and you'll just see this slightly brighter. Can be hyper or hypo to mixed echogenicity depending on the amount of fat, water and cellularity. So just keep that in mind. As I've mentioned, they do have varied appearances. Some have those well-defined margins and others not, that I've talked about, and no vascularity. So that's why you need to be able to put that colour on to differentiate from any lymph nodes or any other more sinister lesions. Sebaceous cysts, our little friend the sebaceous cysts, very, very, very superficial and tiny. So they are benign epidermal cysts that are also called keratin cysts, and they're very, very palpable. You can feel them. That sometimes they can be quite hard, particularly if they've been there for quite a while. Now, they tend to be in more oily skins, younger people who have more oily skins generally, but they can still extend to people in their 50s and 60s. So it's from those swollen sebaceous glands that we all have, and becomes an infected hair follicle. It forms that crust over the top, and you'll get this hard, tiny little lump underneath. Tend to be more round, can be slightly ovoid, but quite small and round and superficial with very well defined borders. They're nice and easy to see, but you have to cast your eyes to those very superficial layers and around that skin layer as well. They'll have posterior enhancement because it's a cyst, as you know. Some will have low level echoes if they are starting to resolve, and look for extension into the dermis so that you're going to see whether or not it is changing. If that infection doesn't resolve and it starts going into the dermis, because it can form a bit of a nasty abscess if it's not treated. So here's some, you can see that little tiny ovoid. See how superficial it is, how close it is to the skin surface. So you need to make sure you really reduce that depth so you're looking very, very superficially, and making sure now looks like there's a box over here to check the colour to see if there's an infection going on, because we do need to rule out that there is any type of abscess formation going on. So here we've got a bit of edge shadowing, that posterior enhancement there, looks like a few low level echoes as well. Hemangiomas, they look a little bit nasty, don't they? And again, quite benign, quite common that you'll see them, and they're found often in the liver, and you'll see them when you're looking at the liver next term, and you've probably seen them already with abdo in your theory aspect that you've been looking at this term, but can also affect the skin, and some of you may already have some little hemangiomas that you've got yourself. Now they can be present at birth, and that's when you get these little pink ones here, which are like little pink raised birthmarks, and they can disappear totally as children grow a little bit older. They can be reddish, raised palpable lumps, and generally only have any intervention depending on the location and if they're in a part, particularly if it's on children's backs, or for young people where the jeans line is, if something's there rubbing it, because it is raised from the skin, often they'll constantly catch them and they'll be bleeding, so they may need to surgically remove them. So you can see they're those little red raised little pinkish lesions, totally benign, but they do tend to keep an eye on them to make sure that they aren't changing or that anything is going on with those. Now metastases and lymphoma, I'm not going to go loads onto that because they're not as palpable, and something that is not as often a scan for you in terms of superficial structures, but I did want to include them because it is a differential that you may need to consider if you're seeing something that you think might be rounded like a sebaceous cyst, but it might have a little bit of vascularity. So it could look a little bit like a melanoma, for instance, or something like that. So we'll talk about a couple of other little lesions that you may come across. So you could get these metastases. They can come from any type of malignancy, so patient history is important. Keep in mind though that that patient may have absolutely no idea that there might be a primary tumour somewhere else. 50% that we're going to see in the superficial area is going to be from melanoma, from the skin, lung cancer and breast cancer, and they're the most typical that we're going to see coming out into the skin. Well circumscribed, they're solid, not compressible, and they're hypoechoic masses. They can have those lobulations as well, and they will have that vascularity, generally peripherally, and the feeding internal vessel, which we've talked about with the lymph nodes. So having a little bit of a look here at the melanoma, you can see how similar this looks like compared to the sebaceous cyst that I looked at. So make sure that you do that colour. Here we can see that little feeding vessel. You can see the difference, it's a little bit deeper, but those borders aren't as well circumscribed as we saw for the sebaceous cyst. And the same here, we've got a visual look at this one here, so straight away you would have to have some suspicions just from looking at it, and when you're taking your images you would need to obviously be making some landmarks, having a look at that vascularity as well, how deep that this lesion is going down into the skin, and whether it is going to start obstructing other vessels, or if it is crossing across tissue planes. All those sorts of things that are indicators of malignancy from lesions that you've learnt from the thyroid and from the breast previously. Sarcomas. So what are sarcomas? There's a few different types. We've got the liposarcoma, the leiomyosarcoma, and the fibrosarcoma. Not as common, not going to spend a great deal of time on them, just so that you're aware of what they possibly could be if you do come across a particular lump that you're not quite sure what it is, if it's solid appearing. So with the liposarcoma, it is a tumour in the fat, so you do need to be aware that not every lesion within the fatty tissue is going to be benign. So it's mainly in the thigh that you'll have, so a lot of quite sinister things are in the legs, and a lot of the mets that you would have seen from the melanomas often appear in the legs as well. Often will be older people, 50 to 65 years old, and you can see what they look like here. They're quite well circumscribed. Straight away you should have some suspicions it's solid appearing. You would need to see whether it's compressible and look at that colour flow. Anything that was a lipoma wouldn't have that type of colour flow, so you'd have to start having some suspicions. Then we have the leiomyosarcoma, which is the tumour of the smooth muscle, again in the periphery, so the arms and the legs, not as common. And the fibrosarcoma, which you very rarely see, is in the fibrous tissue, the legs, arm, or it can be on the trunk, 20 to 60-year-old. The main rule of thumb for any of these sarcomas is this colour, to see whether there is colour there, to see whether it's compressible as opposed to those lipomas, because you could see if I just gave you that image there, you could think that looks just like a lipoma that I showed you earlier. So keep in mind that detective hat that I said to have on. Think about all the things. Is it crossing tissue planes? Is it compressible? Is there any vascularity? How far from the surface is there? How deep is it? Are there any other structures close by? All those sorts of things. Is it starting to draw from other areas when it's getting that blood supply and starting to go across those tissue planes? So start thinking about those things. I hope you enjoy your little foreign bodies scanning, and you get to do some when you go on clinical. And that's going to be it for this particular session. And if you do have any questions, certainly have a bit of a look at the forums and you can post them there. Okay, bye.